They have substrate, and such a dangerous substrate that cobra in pocket which can bite any time. So this is like situation. So he's apparently healthy, but actually he's not. So this is the definite premature CAD. As all of us know, that is premature CAD is very peculiar to South Asian countries. In men, we say when it is less than 55 years. Women, we say when then less than 65 years. And we come down to this. That is a family history, 55 and 65. This is 10 years cut off for hormonal protection, which I also see now premenopausal women also showing rising incidence. And when that is premature or malignant, when presentation becomes less than 45 years and women become less than 55 years. Often it is linked to traditional risk factors, but I find that many times most of the traditional risk factors, which are apparently not there except for smoking. If person is diabetic, how long he would be diabetic at the age of 30 years, around 3 or 4 years. And they are hypertensive also, but diabetes duration is less, or they are non-diabetic. The most common factor is dyslipidemia or smoking, which are apparent, not diabetes as per duration. So many are hidden factors. Having a premature CAD sets 5 to 10 years earlier than Western counterparts, and it accounts for 15 to 20% of ACS presentation in this part of India. And significant problem, all of us aware, irrespective of social class, irrespective of city, irrespective of socioeconomic status, young are definitely susceptible to sudden death or malignant presentation of ACS. So young, now they account for 10 to 15% MI worldwide, and India that maybe sometimes I find many times in CCU, that out of 10 admission, at least four or three or four are less than 40 years of age. So this trend is very disturbing, and as a community, we should be responsible for young patient. Why this enormity? Whether there's some hidden factors in a consistent way that are playing havoc on the life of young people, or that is an interplay of various random unrelated factors which target young persons, because young person is active, exposed to so many hazards which elderly person may not be. So this is just a random convergence of so many factors, or it is an interplay of these random factors with traditional factors superimposed on genetics. So this is a synergistic storm of genomics, metabolomics, or polytomes, or they are interacting and aggressively presenting as ACS. It may appear random, but it is not. It is a long-standing molecular endothelial injury, which can be in the form of plaque rupture or plaque occlusion, or it can be in the form of this is a calcific nodule. Sometimes also event looks sudden but takes decades in making. Now, last week I did one case, that 32-year-old male, he had sudden onset chest pain. There's a family history of CAD in the father. He has a left vein occlusion, left vein thrombus was there, and he was hemodynamically collapsing, and he has a widespread ST changes. So although we say that young person has a discrete lesion, simple lesion, clear lesion, single vessel disease, but we encounter practically sometimes we have DVD, TVD, or we can have left main involvement, and he has only history of family history was positive, and he was a smoker. So this is one presentation. Then I did another case. There's a 32-year-old male smoker, has chest pain, diaphoresis. There's anterior MI. This is thrombotic occlusion. So we find so many. This is a female who is 40-year-old. She's only diabetic, premenopausal. She has all the bases having discrete or tubular lesion, multiple lesion, widespread atherosclerosis. Although they can be stented, but see premenopausal women with diabetes only for 5 years or 10 years, and she had lesions in all the arteries. So females are also not immune. Young females are also predisposed to this malignant atherosclerosis. Now there's a 35-year-old male anastemi post PCI to LED, and now see he has this ISR, and this is a very ugly looking lesions in LED and ISR, and this is planned for this is see how what has happened to this, that is aneurysm, or there's a diffuse ISR, and this proximal LED hole involved patient, and he had this stenting done at some other hospital at the age of 33 years. So presentations are varied, and presentations are very difficult, and sometimes we see what young patient, if he has DVD or TVD, whether we should advise CABG at the age of 30 to 33 years. It is not practical, because redo CABG is also a difficult option. So as per se, that is this premature CAD is very rampant in South Asia and African countries, and you can see India here, and percentages 0 to 15 to 20%. It is very high. And India, China, they have very high as compared to United States, Indonesia. So the global burden show the premature onset is Mean age at first MI is 10 years, 15 years earlier in South Asia as compared to Western population. Prevalence has increased to 12% in urban, but rural is also showing it has increased for 4 to 6%, and slightly females have also shown upsurge from 14% as compared to previous 12% in last decade. So these all registries, Indian work has been done in young CAD. All of us are aware, or we only quote this. CAD registry 22 center include Jaipur, Coimbatore, Tamil Nadu. They picked up high prevalence of family history, diabetes, and tobacco as a risk factors, and family history was 50%. It was only on the basis of clinical. That is, a mother को MI हुआ 65 years के इससे पहले, या father had documented MI or C angioplasty before the age of 55 years. Then there was a Carol registry, vascular registry, focus on 20 to 40 years, and 22% have less than 50 years. Then Tamil Nadu registry and Jaipur Heart was 1, 2, 3, which tracks conventional emerging risk factor in young adult. It also identifies high burden of dyslipidemia, central obesity, insulin resistance in Indians at much younger age. Then there are other study from PGI also, AIMS also, this thing at all, scattered study, Agarwal, Dalal, and all they have shown that is they have highlighted the role of family history, dyslipidemia, smoking, and no one has mentioned novel factor except AIM Rishikesh study 2024, which has highlighted novel biomarkers, and that is some other hidden risk factors and lifestyle drivers in young MI. So although now so many novel risk factors have been giving importance, only problem is how to quantify them. It is not easy to quantify newer risk factor, like we can quantify blood sugar, we can quantify HbA1c. So these are the different studies which have done in Indian subset. Many have been published in Indian Heart Journal also. So hypertension, all these traditional risk factors have also converged, and they have also increased in incidence and percentage wise from hypertension, diabetes, impaired fasting glucose tolerance, or obesity, physical inactivity. Although smoking has declined, but because of vaping, or it is prevalent in other forms of tobacco consumption, and typical Indian pattern. So Jaipur Heart was 1, 2, 3 in year 1994, 2000, 2003. They have again highlighted the role of hypertension, smoking, dyslipidemia. Not beyond that, not beyond that. They have not touched another unidentified risk factors, which are very difficult to quantify, because a picture cannot be explained only by the basis of traditional risk factors. Indian patients, young patients especially, they have high triglyceride, very low HDL. In our studies, also I've done many theses on that. HDL is low. It is very uniformly seen that HDL is very poor. Qualitative LDL is bad, quantitative it not be very bad. A small dose LDL has been found to be very high, which causes endothelial dysfunction, is prothrombotic, lead to diffuse and premature CAD. So we know, just to go through this slide, that two type of HDL also. One is HDL large buoyant, other is small dense. So HDL also, they're relatively good and bad, and they have this composition, and they had this is large buoyant is slightly more protective as compared to small dense, just like LDL, which is small dense, which is more pro-inflammatory, prothrombotic, and tendency to form clots. So not all HDL particles are protective. I think thesis should focus more on the basic sciences and type of LDL and HDL which we have in our system. Then another focus shifted to ApoB and ApoA1. ApoB is the number of atherogenic particles, which is direct predictor of plaque burden. ApoA1 is anti-atherogenic. Now focus shifted, instead of rating all the lipid profile, although center is LDL, but we should also look beyond LDL. One is ApoB and ApoA1. Low risk less than 0.7 ml, 0.6 in women, and high risk is more than 0.9 in men and more than 0.8 in women. So ApoB and ApoA1 is another way to look at the dyslipidemia, which is best global marker of lipid-related risk. And this should also be taken into consideration. There's a different way to read the lipid profile report rather than going through basic triglyceride and VLDL or LDL. Now, this distribution risk factor in young CAD, smoking was found to be 33%, family history 28% on clinical basis, dyslipidemia 8 to 10%, obesity 13%, diabetes 6.3, and hypertension 11 to 12%. This is a different other publication which have shown that proportion of all MI is 20-25% below the age of 45 years, 10 years younger than Western counterpart. Urban rural, they have risen present 14%, 6%. Major risk factors are these: smoking, diabetes, dyslipidemia, central obesity, family history. And most common angiographic pattern is single vessel disease. Out of single vessel, it is LAD, proximal LAD, discrete lesion, thrombotic lesion. And 66% in our thesis, they are single vessel disease, 20 to 25% they are RCA, and rest are the LCX, and 15 to 20% DVD, or 8 to 10% are TVT. So in our thesis also, we have found same pattern. So Indian population, I've already discussed, the prevalence is definitely rising for the last 10 to 15 years. By in India, state-wise also, urban, rural, they have shown rising incidence over the year. This is a state with Kerala, Delhi, Tamil Nadu, Maharashtra, Karnataka, Punjab, Uttar Pradesh, and West Bengal. So the rising trend, rural and urban, over the decades together. So most common in young male pathophysiology is plaque rupture, which is 60 to 70%, which is eccentric, non-calcific, and it ruptures include 30 to 40% plaque erosion, and 3 to 5% is calcified nodule. And interestingly, if we compare young male with young female, in young male, most common cause of ACS stem is plaque rupture. Young female, plaque erosion is relatively more as compared to young male. In young male, the fibrous, this cap thickness is very thin, cap fibroatheroma, which are likely to rupture any time. In females of age, cap is not so thin, cap is slightly thick. This may be because of hormonal protection. So that's why plaque rupture is not so high in young females as compared to young male. Young female plaque erosion is slightly at higher percentage as compared to young male. So young male, most common pathophysiology is plaque rupture. Young female plaque erosion is slightly more common because they are not having so much thin cap. They have relatively thick cap fibroatheroma, which is somewhat protective. So this is, as if we compare young versus old, young plaque burden is lesser, lesion length is lesser, plaque volume is smaller, revolving is less negative, fibrotic osteal tissues, and thin cap and thick cap I've already discussed. Spotty calcification is less frequent in young, and plaque rupture, plaque thrombus is more common in young as compared to older person. And females, usually they have more incidence of menopause, incidence of spontaneous coronary artery dissection in females, especially in pregnancy or in premenopausal, they have high incidence of spontaneous coronary artery dissection. And I've already discussed about plaque erosion and plaque rupture. So this compared male and female. Microvascular dysfunction is more common in female, and females are more likely to suffer from syndrome X vasospastic angina as compared to male. Although male can also have, especially if they are a smoker or they are addicted to cocaine or amphetamine-like drug. But spasm is a known phenomenon which has been shown more common in female, who usually present with atypical symptoms. So this OCT image is a plaque rupture, plaque erosion, and calcified nodule. All of us are aware of what are the OCT looks like in the case of the plaque rupture, which is discontinuous fibrous cap accompanied by frequently by empty cavity with or without superimposed thrombus, while erosion is irregular luminal surface with no evidence of plaque rupture accompanied by superimposed thrombus. And calcified nodule, we are all aware, there's a protruding signal poor well delineated lesion with sharp jutting angles, very difficult to treat sometimes because like a monster, which again grows and grows, and repeated presentation by patient in cath lab. So this is a diagrammatic representation, and just to make it clear, that is because this is because many times plaque erosion does not require stenting and plaque rupture requires. And although imaging further differentiate, there was one paper, one patient we were doing with Ankush also. He had young MI and he presented with transient CHB. And when we look at angiography was relatively normal, analyze LED, and then we do OCT imaging, and OCT we could find that is a plaque erosion in left main, and that was responsible for CHB, transient CHB. So this is the importance of imaging. So we could detect there is the erosion which was responsible MI and CHB because of large extensive anterior wall MI. So this is how this is high. We should not shy from basic sciences. We may remember, we may not remember everything, but we have working knowledge about inflammatory cascade, T cells, fibrin rich, ApoB, monocytes, endothelial dysfunction, how this interleukins act, how tumor growth factor acts, and how they lead to leukocyte recruitment and resident macrophages and role of MMP collagen. We should not go through every time. Every time we are not supposed to remember each and every step, but at least it helps in working knowledge, because unless we revisit our basic sciences at this level, we will not be able to solve the problem at clinical level also. So this is histopathology of plaque rupture, which is having superimposed thrombus, a total clogging of artery, and these three are OCT images, which we have already discussed. Spontaneous coronary artery dissection responsible for 1 to 4% of MI cases, and females it is not 30-40% also in premenopausal. There are three types: multiple lumen contrast stating, type 2 is diffuse smooth tubular, and type 3 is focal mimicking atherosclerosis. Sometimes it is difficult to look angiographically. It can be looked at in the form of layered thrombus unless we have imaging. And most of the time we can come out with conventional or conservative treatment unless there's hemodynamic compromise and flow is limiting, or there's some patient is quite complicated, and patient is having ongoing angina, hemodynamic stress, we may require standing, but most of the time it should be managed conservatively. If it is non-flow limiting type of dissection, it is better not to intervene. With the help of putting wire and all this, we can go away with the medical treatment, but sometimes it becomes difficult when patient is having chest pain and hemodynamic compromise. So this is, it can be either the plaque rupture, erosion, hypercoagulable state, vasospasm, embolism, autoimmune related, or it can be coronary artery dissection. So sometimes when it is left main, proximal LAD, large intramural hematoma, flow limiting, then we have to intervene in that case. Spasm, there are so many factors apart from female. If triggers are there in the form of anxiety, smoking, cocaine, recreational drugs. Earlier we used to study ergonovine or acetylcholine spasm test, but I don't think anyone is doing now. So this is a spasm and very typical presentation. We also refractory. This is Prince ventral angina, early morning chest pain, looking elevation in my head. So spasm is definitely a special problem, which has to be suspected and which has to be dealt like that. And some factors definitely trigger, and some inherent factors are there which predispose the patient more towards tendency of a spasm. Now we come to other causes which can lead to in young patients, especially in the form of drug abuse. Drug abuse is very rampant. No class is immune to drug abuse now, drug addiction. Lower class, higher class, now middle class also, high-fi city like Chandigarh, Bangalore. Now to middle class or lower cities, A, B town like Aligarh, Hathras, Agra also, drugs are available everywhere. And parents have no control because drugs are available from other sides also, and a child is person is addicted to gadgets, and if he's influenced, procure drug from any source. So cocaine is responsible for MI, amphetamine, MD, MA, all these lead to myocardial oxygen demand, vasospasm, thrombosis, direct toxicity, and can lead to massive MI and sudden death also. It can lead to VT also. There are another, especially in young females, more common, or males also, if there's a history of Kawasaki. If you look coronary artery angiography, we look aneurysm, either it is atherosclerosis or there is a previous history of this Kawasaki disease in the childhood, which was undiagnosed, untreated. Then it can be panarteritis nodosa, giant cell arteritis, or then it can be in the form of chronic vasculitis, Takayasu, more with osteal lesion. Hypercoagulable state, factor 5, factor 8, EPLA syndrome, antiphospholipid, malignancy, nephrotic syndrome, von Willebrand factor, protein C, protein S, there's long list, hyperhomocystinemia, peculiar causes, a subset, which is genetic causes. And sometimes when we filter down looking at this, sometimes we encounter that person is having some inherent problem leading to more hypercoagulability. So these are inside their traditional risk factors and surrounded by sleep disorder, that is obstructive sleep apnea, gut microbiota, that is a biomodel, air pollution, diet style, psychosocial factor, vitamin deficiency, and hyperuricemia. So 90% heart attack can be prevented through education. Although whatever genetics say, much is in control of the person, lifestyle, and control of risk factors. He can definitely revert many of the inherent dangers superimposed on him because of genetics. He cannot say I'm doomed to have MI. We cannot say like that. So many things you can control, and Interheart study also has shown these are the list of the risk factors which can be controlled also. Now, some other novel risk factors which have been giving importance in the last decade is one of them is air pollution. High level of PM 2.5, especially significantly increased cardiovascular risk because of air pollution. Another important identified risk factor is obstructive sleep apnea, which people have. There's a metabolic syndrome, and then a VT, and high HbA1c, dyslipidemia, hypertension, low oxygen saturation in the night. All these can have this, all this metabolic profile is push towards having some vascular event in the form of stroke, in the form of heart attack. Post-COVID, I don't know, we don't know how many are having sequelae of after COVID. When COVID affected crores, then definitely lakhs and crores must be having post-COVID syndrome, especially those who have required admission first time, whether they're vaccinated or not. Definitely, there are large number of people unidentified in India who are living with the residual imprint of COVID in the form of endothelial dysfunction, in the form of low-grade inflammatory state, in the form of tendency towards clot formation. We don't know because we don't now run OPDs which can select those patients and look for residual damage in the form of HB1C towards heart checkup or towards CT scan thorax. We are not doing that. So we don't know. Looking for inflammatory markers also. Then another risk factor which has been identified, the inflammatory states. Inflammatory states. A young person comes with very high level of HSCRP because he accidentally that level was checked by lab and HSCRP is 15 and written below that HSCRP 2 times, 3 times can lead to heart attack, and he has read that he is very anxious or his parents are anxious. We cannot tell any specific anti-inflammatory drug because that has no role. We can only suggest if he is having blood pressure, anything, dyslipidemia, apart from lifestyle modification. Because still now no anti-inflammatory drug has shown to having any clear-cut benefit. So HSCRP, whatever we cannot tell except for lifestyle modification or another risk factor which can be treated, not directly any drug for HSCRP. Substance abuse, low socioeconomic status. The patient is obese persons, they have definitely obesity paradox, but even low BMI, most of them, they can have heart attack. Malnourished patient, they have another type of risk factor where there's an inflammatory state and they are equally predisposed to have heart attacks. Dental hygiene, oral microbiome, and trans fatty acid. If trans fatty acid are more than 4% energy is consumed from trans fatty acid, risk of ACS is increased to 25%. So trans fatty acid, the margarine, vanaspati ghee, or there's a reheated oils, they lead to high LDL, low HDL, high inflammatory state, interleukin, endothelial dysfunction. Over 2% energy consumption of trans fatty acid lead to increased risk of CAD by 20 to 25%. 20 to 25%. So vanaspati should be banned. I was reading that Denmark, one country which identified that there was this saturated, hydrogenated ghee was responsible for high incidence heart attack, and they banned that. And in last 20 years, this sudden MI or MI young population has come down by 40 to 50% in last 20 years. Denmark has been quoted. They have banned such. So such foods which are having high level of trans fatty acids, they should be banned. They should be had. Then another practice is by Indians, they use oil. ऑयल गरम किया, वी हैव फ्राइड, डीप फ्राइंग, एंड जो ऑयल बचा उसको ठंडा करने रख दिया, इट इज कूल्ड एंड इट इज रीहीटेड. Reheating of oil, this cooking practice of the oil, which lead to high level of trans fatty acid when it is used another day. And that's why there's no marked difference between a person who is purely vegetarian and a person who is having high consumption of non-veg. I think the key lies in oil, consumption of oil, quantity of oil or cooking practices. So this is this because lead to rancid oil and high level of trans fatty acids. So this trans fatty acid should be studied more, and we should inquire more from the diet, that is which food they are taking. Other oils, there can be palm oil, coconut oil, high level of coconut oil. In Kerala, they have high incidence of heart attack. Then all this, we should go more for quantity rather than going for one type of oil, because one fatty acid deficiency in one oil can be compensated by other. Even mustard oil is not bad. Even if a person is not rich, he can use mustard oil. Person can sometimes use olive oil, sometimes sunflower oil, but he should avoid all this palm oil, coconut oil, or vanaspati and type food. So shift to mono or polyunsaturated fatty acids blends better with lipid profile, and they are low inflammatory. Another important thing which I was discussing, reading related to this seminar, diet, different diet, and one diet which has been found to be highly controversial is keto diet, because keto diet is for energy, there's weight loss, and keto diet, I think more studies required to it, but this looks definitely culprit in many cases. Those who are more conscious about their body shape and weight, and they just want to lose weight this way or that way, because keto have low carbohydrate, high fat, and moderate to high protein. And this definitely lead to insulin level low, glucose oxidative stress, and definitely there's some benefit has been shown lipid profile, but it leads to inflammatory state. It leads to increased LDL, ApoB, and endothelial dysfunction. So as we say, you may be looking like a hero. Your muscles are very strong and six packs, but your arteries are very weak. Your arteries are very weak from inside. Only cardiologist knows, because we know that why the gym trainer or gym person is suddenly collapses in the gym. He's regular for last many years. Why he collapsed? Because one factor may be diet or gym supplement. Muscles are strong, endothelium is weak, and endothelium is a real thing to focus on rather than on biceps and triceps. So some dietary pattern required to be require revisit and should be checked. And keto diet, I think, is a culprit, and more comments are required on keto diet. So this leads to high level of LDL, ApoB, small dense LDL, nutrition deficiency, and poor gut microbiome. And gut microbiome definitely affects inflammatory state and pushes towards heart attack. Then another important inherent factor is familial hypercholesteremia. If we say we pick up one person who is having FH, we have picked up one family. Although there is very isolated families are there, but you think whole family is like a ticking atom bomb. And this is autosomal dominant, and they're very high risk. All the family members, most of them, clue is when there is a sudden history of death of family, then other person comes out, or person definitely has some vascular event, they come out. And then when we look at it and we look at lipid profile, a very high level of LDL, 200, 300 milligram percent, and xanthoma, xanthelisma, and every these clues are there. We call other members, and many members are having that is very high level of LDL especially. So the genetic mutation in LDL receptor, which is required for 80 to 85% cases, ApoB mutation 5 to 10% cases, PCSK9 mutation less than 5% of cases. So these genetic mutations, they can lead to heterozygous type or homozygous type. So heterozygous is 1 in 250, homozygous is quite rare, 1 in 160,000 to 1,000,000. So LDL is very high. And everyone must have seen one or two, a few cases of FH. And definitely there can be some history of sudden cardiac death or history of heart attack in younger brother or elder brother and everything. So this is quite malignant, and this is one of the subset affecting CAD in young persons. There are so many criteria to diagnose and label FH1 is Simon-Broom criteria, that is Dutch LCM diagnostic criteria. And I am not going to detail another criteria to diagnose FH, but instead of rectifying that, we should we are definitely by clinical history, for family history, and looking at lipid profile. Then we go aggressive. In asymptomatic person, we should go up to CT angio or a functional test, a stress test. We should not leave only at the level of blood test or normal ECG or normal echo. We should be more aggressive in looking at the coronary, some substrate, plaque formation, or calcification, and other members also. Or do bituminous stress test is required sometimes. So 1% we have this familial FH, and he diagnosed, and he finally had to be 325 milligram deciliter in our GNMC. Then family pedigree analysis, father was having high LDL. Then this is the person with the arrow. He has one sister, LDL high, another brother also LDL high. And this person was married, he has two sons, and both sons were having high LDL. Now you see in this family, out of 1, 2, 3, 4, 5, 6, 8%, at least 6 were having LDL. So we have picked up one family which is at high risk of ACS event sometime, anytime in their life, as per precipitating or triggering event. So FH is underdiagnosed. It is not so rare as it seems to be, because one FH case means 5 or 6 family members also picked by through one case. So this is one my paper. I did also this presence of familial dyslipidemia in patient premature coronary artery disease, northern India, in correlation with angiographic severity of the disease. So we did one thesis, although we could not work so much on genetic. Now we will do another thesis. We'll tie up with one lab, look for genetic aspect. Then another important factor, when person has repeated DVT or person has venous thrombosis, arterial thrombosis, some persons definitely have this hyperhomocystinemia, which is, we go back to biochemistry, remember our folate, remember about MTHFR gene, and we remember what is normal, what is mild hyperhomocystinemia, moderate and intermediate or severe. Severe when it becomes more than 100. So hyperhomocystinemia leads to endothelial dysfunction, oxidative stress, prothrombotic event, inflammatory as well as oxidative stress. So we should remember to as adenosyl cycle of homocysteine and folate cycle, and we should look for this. That is basically why it is happening. That is hyperhomocystinemia becomes prothrombotic factor, and it is quite treatable. It is not so costly treatment. We have to document it, but treatment is not so costly except dietary modification, and we can give supplement this folate and homocheck. So low dietary folate, vitamin B12, vegetarian, malabsorption, genetic also. There's a MT, HFR or C6770 polymorphism. So AIMS New Delhi, Jaipur Heart Voice, South India, Tamil Nadu, Kerala registry found many cases of elevated hyper homocysteine in young MI versus control, a strong correlation, low folate, vitamin B12. Elevated homocysteine as per Jaipur Heart Voice was 18 to 25, urban middle class associated low vitamin B12 intake. And Kerala registry showed that elevated homocysteine can be associated with high CRP and multivessel CAD. Another is polytome model. We don't give importance to these factors, but young person is exposed to so many risk factors, variables related to pollutome. One is air pollution, other is light pollution, and sound pollution, soil pollution, water pollution. All these lead to, because he's active, he goes many times, goes to office, crosses all these traffic signal, inhale PM 2.5, coming, going back, now not no longer using mask also. Night duties, more light pollution, sound pollution, air pollution, environmental hazard, we don't know about radiation hazard also. All these lead to systemic inflammation, pulmonary inflammation, hypothalamic pituitary adrenal axis activation, autonomic dysfunction, and thrombolytic pathway activation. These lead to ED, oxidative stress, platelet activation. All these epigenetic changes lead to hypertension, diabetes, dyslipidemia, thrombosis. And problem is we don't know, everyone is exposed in metros, even in B grade cities, all these factors, person in night duty every time, working in night calls and sleeping daytime. So most of the light is on. He's not able to, he's not following this rhythmic pattern, circadian rhythm also is disturbed. So, but how to quantify that? How to quantify? Only artificial intelligence can help us hovering over the cities and as a community. Otherwise, as a plan, it's very difficult to individualize in the form of some unit. So this is a polytome model. This is a distribution of PM 2.5 in America. And India also, I could not find any cover, but in America also, this is red area, very high level of PM 2.5. Microgram per cubic millimeter exposure, 9.58, 16.9 is a red one, followed by orange. And India, you can see, picture will be much worse. And we should know that is the potential damage of PM25, each 10 microgram per cubic millimeter. This is millimeter, not meter, sorry, millimeter increase in PM 2.5 was associated 28% increased risk of CAD. And if that person is genetically predisposed with high BP and high LDL, then it acts as a trigger. High BP, person is hypertensive, genetically is having LDL. Now he is exposed to long-term PM 2.5 exposure. He can have high level of very high risk to PM25 2.5, which can precipitate heart attack in the form of plaque rupture or plaque erosion. So this should not be underestimated. It should be highlighted in various papers. There was ESC paper which showed that this is definitely one of the most important, one of the most novel risk factor. which is playing havoc with the life of young patient. So this is how it is playing havoc, right from hypothalamic pituitary to direct autonomic endothelial dysfunction, systemic inflammation, thrombolytic pathway, and thus activating all this pathway and leading to oxidation reduction injury and all this low-grade inflammation, and finally inflammatory cascade. So years of life loss based on PM 2.5 or model using Gombert's parametric model, which provided best for this. Best fit. The study of relationship between particulate matter, air pollution, major adverse cardiovascular event. So this is some studies definitely are emerging, which are highlighting and they are supporting that PM 2.5 and air pollution behind that should not be underestimated. It can lead to stroke, it can lead to ACS, definitely. Then we come to another, there's the oral microbiome, dental hygiene, small chain fatty acid, bile acid, uremic toxins, and lipopeptide, they lead to platelet hyperactivity, lipid metabolism, obesity, insulin resistance, and this can lead to atherosclerosis. So dental hygiene. That's why we have in rheumatic heart disease, we definitely ask the person to go and visit dentist with rheumatic profile access. We say कि वॉल में infection है तो फिर dental hygiene should be definitely checked. For CAD also, we should always focus and we should advise the person to maintain his oral hygiene, dental hygiene, and oral microbiomes. They should be addressed. So there are some flora which have been found to be implicated in this one. These are some of the bacteria which have been found. One is Porphyromonas gingivalis, other is Tenderella, Trepona, Fusobacterium. All these have to be leading to endothelial dysfunction, inflammatory state. And they have definitely been found to be implicated in various forms in the form of plaque formation or carotid intima thickness or endothelial dysfunction. Then gut heart axis, जैसे कहते हैं दिल का रास्ता पेट से जाता है, so gut microbiome, these have been implicated. Enterobacteriaceae, Clostridium, or these are Prevotella, Bacteroides, they lead to endotoxin, they lead to cardiovascular event, endothelial dysfunction, insulin resistance. All these, they should be required to be studied more detail. Now, when we change the diet, we go to this burger food, or most of us are traveling here and there, and they take whatever food is available. Definitely, microbiome of gut is also affected, and this your whole flora is changed. Don't understand these factors, but we don't go about it how to quantify. Because see, there's a B and C column. There are a lot of things to be read here. Interleukin 1b, 6, endotoxin, SCFA production, gut integrity, which definitely lead to atherosclerosis in the last column. So now we come to another important factor which young person is vaping. That is the electronic smoking. That is, vaping has been found to be, it came with a lot of glamour and all that, but is found to be almost same level or maybe dangerous equally. And in some aspect, it can be more than that because it is a battery operated with the heavy metal, and it came as a glamorous statement, a dual pathway. Young persons tempted to adopt this vaping, but definitely he come to traditional pathway also, with the combustion is the process. Here is the battery operated heavy metal. He can adopt both type finally. And e-cigarettes, they have heavy metal battery operated through heat, which have nickel, which have all this heavy metal in the form of nickel or cadmium, cobalt, and these particles have been found in the lung, and these particles have been proven to be carcinogenic. So they can lead to carcinogenic apart from these constituents, which are also harmful in the form of marijuana, nicotine, menthol, cinnamon. All these solvents also, they have been found to be heavy metal, and they have uh, thrombogenicity, arrhythmia, cardiac dysfunction, or vascular injury, or sensitive sympathetic activation. So these are after COVID-19. I will not go into detail. I will also not go into detail of OSA, but OSA can lead to systemic hypertension, sudden death also. A person can be on ventilator once person has chest infection, pulmonary hypertension, ACS in any form. Initially, it is very difficult. High level of suspicion is required to diagnose OSA because OSA can lead to LV dysfunction. We should go sleep study, look for AHI index, and if it is very bad, it will not go with dieting alone. We have to person has to buy the machine and non-invasive ventilation. Lifelong he has to use it. Irrespective of weight loss initial response, he has to carry the machine with him wherever he goes. And he can be only, it is not a disease of only sleep and awake and sleep. It is more than that. It can lead to sudden cardiac death also. It can lead to VT. It can lead to rush upsurge of catecholamines. It can lead to stroke, MI, everything, diabetes. So everything is derailed if OS is not treated. So this is just to highlight how dangerous is OS. Undiagnosed OS is very dangerous. And person is unaware and family thinks person is addicted, is taking alcohol. So then another thing, yeah, you have read the gym supplements. One is steroids. Gym person, all sort of abnormal diet, keto diet, and all this cocktail of stress, body weight, obsessed with body weight and fitness, anabolic steroids, high dose. If there's a creatine which is more than 5 gram per day, it is dangerous. And creatine can lead to dehydration, renal stress. It can lead to inflammatory state. Energy drinks performance can lead to vasospasm, arrhythmia, catecholamine surge. High sugar drinks, dyslipidemia, insulin resistance. Anabolic steroids can lead to inflammatory state, polycythemia, protein powders, dehydration. All these can play havoc. These are like dangerous cocktail. And a person is addicted, फिर तो कहना ही क्या उसका. Gym person is addicted, he's in some glamour industry or obsessed with his image. So it is just like interplay of so many factors. But as far as gym supplements are there, they should not be taken without supervision because high creatine can also be dangerous. Anabolic androgenic steroids are bad for heart. Then there's a lot of things which could done in the form of the risk factors, novel genetic factors, which can be in the form of lipoprotein A, genetic polymorphism, FH, ethnic susceptibility, telomere shortening, Y chromosome haplogroups, intrauterine programming, epigenetic modifications. There are areas of research. Another is lipoprotein A, which is apolipoprotein B containing lipoprotein bound to hydrophilic, highly glycosylated protein, apolipoprotein A, together with oxidized phospholipid. There are half component to lipoprotein A, which is related to young MI, a stroke or peripheral arterial thrombosis, or wide range of SCVD condition. And lipoprotein A, is not affected by exercise or diet. It is intrinsic. It is related to chromosome 6. It is genetically driven. It is very bad. And it leads to pro-coagulable state, pro-inflammatory state. And I have found in my studies that is around, in our study, 8 to 10% of our young patients, they were having lipoprotein A, which was 2 or of normal, and very difficult to respond to statins or diet modification. So they're very refractory to statin, or statin hardly can do anything. It may increase also sometimes the level of lipoprotein A. It can it can lead to stroke, and it can lead to so many factors related to vascular events. So this is lipoprotein A more. If there's a family history, a young person, then always ask to the person to check for lipoprotein A beyond lipid profile, because lipid profile will look cursorily okay, but if you go for ask the person to check lipoprotein A, and you will be surprised the lipoprotein A was undiagnosed 2 or 3 times more than normal. And it is the culprit in that person. It may be responsible for ACS in that person. So only 2 drugs have been found to decrease lipoprotein A. One is that is Repatha type, PCSK9 inhibitor can only decrease lipoprotein A, alirocumab or evolocumab, or it may be inclisiran also, but it is refractory to statin and refractory to bempedoic acid. And if it is refractory, then definitely Cobra is there. It has to be advised to take PCSK9 inhibitor or inclisiran. So this is the toxic potential or dangerous preparation of lipoprotein A. Inclisiran can be life game changer, and now many cath labs in young MI, irrespective of lipid profile level, LDL level, they advise the person to take injection of inclisiran or Repatha before they are discharged. Because and this concept is working because they want LDL to come down as early as possible, because if we take all the particles, then one particle to be given maximum importance is LDL. LDL is the culprit, apart from Rose by ApoB, ApoE1, or lipoprotein in selected cases. LDL, high intensity statins, bempedoic acid, and we should not go then. And many times we directly give Repatha or inclisiran in malignant cases, malignant presentation, young MI. So many cath labs are doing this. They before discharge, they advise the person to take this injection. So all these are different trials which are given in the form for small interfering RNA targeting. They are in process. There's the Ocean, then Orion 11 trial, and we are looking for the outcomes. And these all trials are using these injections subcutaneously. Let's see what are the results. So lipoprotein is definitely independent risk factor for young person or calcific AS also. It exhibits significant race ethnic variation and highest level in the person African ancestry. They do not change after 5 years except in terms of significant inflammation. So everything. It is at the level of chromosome 6 and supported by lipoprotein gene translation. Definitely a strong genetic link and family history is positive. Then another is job unemployment, failure to achieve target by the end of this month. Many young person they have tachycardia. Insistent tachycardia is not good for heart. Labile hypertension. उसके पीछे अगर पूछे एमआर है या कोई इंडस्ट्री में उसे पूछा जॉब इनसिक्योरिटी अगर मैंने 31 तक टारगेट नहीं अचीव किया तो मुझे निकाल देंगे आई हैव फैमिली टू सपोर्ट एंड कॉन्स्टेंटली प्लेइंग विद हिज मेंटल हेल्थ 24/7 he is married he has wife he has children and old parents and no job security. He has to achieve his target this way, that way, running from one seat to another, splitting with him. I'm talking about many jobs, more high profile, my high tension jobs, which are playing. And all they are playing not at a mental level, they translate in the form of endothelial dysfunction, chronic inflammatory state, and all whatnot. So this one. Now we come to another interesting aspect, and I was reading this paper, heavy metal and CAD. So there are heavy metal exposure also, and blood, especially these metals, lead, cadmium, arsenic, mercury, nickel, cobalt, copper, and iron. They lead to high blood pressure, endothelial dysfunction, atherosclerosis, oxidative stress, microvascular disease, ECG changes, lipid profile is deranged, and they lead to oxidation reduction injuries. And these Indian studies from AIMS, Kerala, Tamil Nadu, and also in Bangladesh, they have shown that is blood cadmium and lead they have implicated that they may have a role in premature MI correlated to carotid intima thickness. Arsenic in water, cadmium in rice can be related to subclinical atherosclerosis, high urinary cadmium lead in workers, high BP, ECG abnormalities, and China, CAD, China also, Bangladesh has also implicated cadmium in all this setting. And I was reading this paper from RML Lucknow and Ashish Jha paper, Ashish Jha with Bhuvan Tiwari. They're very interesting paper. They have also seen this in this paper. They have shown that serum heavy metals they were not associated with angiographic CAD severity, although nevertheless higher cadmium level in ACS patient and elevated arsenic mercury level in hypertensive patient suggest that metal exposure may influence disease phenotype rather than plaque burden. These exploratory findings definitely warrant validation in larger longitudinal studies. They found cadmium, although it is not high to significant level, but in ACS subset, cadmium is relatively high. And for hypertensive subset, arsenic, mercury. And same extrapolation in nickel and cobalt also. So definitely ignored, it require more studies. And similarly, there's one paper which मैं ढूंढ रहा था मुझे मिला नहीं, plastic contamination, plastic particles in blood stream. So these are my different theses over a decade where we have tried to look again and again. I'm interested in this topic for MD and DM also different. Young MI. I've also seen in this pharmabiochemistry also, that is the study of modification low density lipoprotein role in CAD and maybe clinical topic DM residents. Females also have studied angiographic pattern, equation I have studied, then prevalence in AMU implies to study the role of immunoregulatory molecules oxidative stress in MI. This was a PhD thesis. So 6 or 8 theses, and we are progressing with now project also. Another important aspect is inflammatory state in CAD. Whatever you say, practically हम अभी तक कुछ नहीं कर पाए. Whether it is canakinumab, whether it is other anti-inflammatory marker, whether it is colchicine, if we give inflammatory agents which can subside inflammatory cascade, we expect the results will be better. हमें ऐसा देखने को नहीं मिला. Now, JNMC is enrolled in ongoing Artemis trial, which could establish interleukin inhibition by this anti-inflammatory ziltivekimab as a new adjunctive therapy post-MI to reduce residual risk beyond lipid lowering and antiplatelet anticoagulant therapies. And JNMC is also enrolled. I am a investigator, we have given 15 to 20 patients of STEMI and NSTEMI as per their protocol. And during that period of primary angioplasty or plasty within 24, 36 hours, after consent, we give this injection also. Idea is just like we are doing everything for MI, everything for antiplatelet therapy. We are not doing anything for inflammatory cascade, high peak of tsunami-like peak of inflammatory mediators. So concept is give this injection just to control tide over this inflammatory cascade with the help of ziltivekimab, which can be repeated later on, and just to look for long-term follow instant restenosis or recurrent cardiovascular or cerebrovascular event. Let's see how it goes. It is international trial, aims PGI, I think, and various escorts and very reputed centers are enrolled. We have also given 15 to 20 patients of Artemis. Now let's see what results say. But till now, the results of different anti-inflammatory, they are not encouraging. So HSCRP definitely the risk. We can do only a lifestyle modification. We can see individual deranged values, but nothing specific as such to target CRP levels. Just to adopt lifestyle in the form of all these factors control, which we have discussed just now. Just like fibrinogen or fish and balanced diet and control fibrinogen, dental hygiene, all these things. So these are the major clinical trials which are ongoing, and Cantos का भी नाम है उसमें, Colcott है, colchicine का clear है, methotrexate, but results are not very encouraging at present. Yeah. So in athletes also, apart from sudden death and hypertrophic cardiomyopathy or arrhythmic athletes also suffer from. Definitely, there is a subset risk of CAD. Don't think person is athlete does not guarantee he's not immune from CAD. Even with well-managed traditional risk factor, long-term high-volume endurance exercise itself can lead to coronary atherosclerosis, though CV event is not risk is not increased. Just because person is doing so much exercise, long-term, high-volume endurance exercise over a period of years can lead to myocardial injury. It can lead to eccentric hypertrophy. Even too much exercise is bad. It is just like U-shaped curve. Even top becomes positive when you do too much exercise. So CAD is definitely there in person who is doing too much exercise, long period. There can be high incidence of coronary calcification. Remember that interesting paper, a person is sedentary, he will have less calcification, and person is doing heavy exercise, has more coronary calcification. Apart from risk factors or other things he is doing, independent of that, athletes are also one subset have definitely risk of CAD. So you don't be surprised if athlete dies suddenly on the ground or collapses. It may be because of CAD also, not only because of SCM or VT type syndromes. This is sportive calcification or become eccentric hypertrophy, LVH or plaque formation or myocardial injury. So management approach, we have to, this missing gap has to be fulfilled. We see that the person is sedentary and person is very active. Now see U-shaped curve. All these foam cell, necrotic core, and plaque, heavy calcification, lipid, again increases. So moderate exercise best. Guideline recommended, which is 45 minutes per week or per day or 150 minutes per week is best. But other extremes are equally bad. And as a person exercises more, is worse than sedentary. So don't be surprised. It is not so easy. Dod do char nahi hote many times. So it is shown so clearly in these athletes or apparently very healthy person. Young female we discuss. Last year I did thesis on young female and my candidate was little worried कि sir young females कैसे मिलेंगे. MI की मैंने कहा करो बहुत मिलेंगे और एक साल में he could find easily 70 or 80 young females and premenopausal females, and they have all sort of presentation, STEMI and STEMI, single vessel disease, double vessel disease. Some were diabetic. No one was using pill. One or two were having APLA. But even in young females, we could find that his incidence is increasing. जैसे पहले कहते थे ना प्रीमेनोपॉजल कुछ हो ही नहीं सकता, it is quite uncommon. I don't think it is true now. Females, although not as common as young males, but young females definitely incidence is rising. So then one thesis we did with a correlation of clinical etiological profile with angiographic severity of coronary artery disease in perimenopausal female. My candidate was Narpinder Singh. Very interesting results were seen in this. So many female without difficulty could easily have 60, 70 cases in 1 year. So these are the atypical presentation and different profile we see. That is a very, very interesting case. So future lies in going back to genetics, chromosome 6 and other CETP polymorphism, a particular lipase gene, fibrinogen, APO E2, single nucleotide polymorphism, APO E4 allele, and all this. Now, role of AI, very difficult. AI can help us in risk reduction, surveillance of young community. If you want to study disease young, through their smartwatches, Fitbit, and all these, we can have data. We can have data in the plethysmograph, ECG, blood pressure, so many data which can translate into so many useful information. And this usually information can like a drone over young communities and can see the trajectory, extrapolate which young patients they are going in which pathway and who are more likely to have ACS event. So we can catch the disease before it causes MI or sudden death in young persons. I think AI has a lot of potential to for surveillance of young community as far as CAD is concerned. So now I've discussed single vessel, double vessel, and all these patterns, Minoka, everything. I will not discuss management because this is not the part. Now I will end up only with the first slides. All these are pharmacotherapies are there. Goal is LDL control in as early as possible, as long as possible, as low as possible. ये formula LDL के नहीं, इसमें U shape कर्व नहीं follow होता like blood pressure, blood sugar. As early, as long, as low. LDL should be as low as possible with the help of exercise and whatnot, inclisiran and all. So future directed life need to study sometimes एक डिजीज को एक ग्रुप में भी पढ़ना चाहिए. जैसे हार्ट फेलियर है, मैं फीमेल्स में हार्ट फेलियर अलग होता है, मेल्स में अलग कुछ डिफरेंसेस होते हैं. So need to study CAD as a group. Indian registries are required to study CAD in young. We as a community are responsible to see a young patient. Research is required to identify, quantify novel risk factor. Need to return with basic sciences for better integration with clinical. ICMR project to link institute like AIMS, PGI, Chandigarh, CMC, Vellore, and Mumbai, and potential of AI to study CAD in young. I think AI can definitely, because it is not a case of individual, it is a case of community. Various interfaces will be clear once as a community CAD is studied. Thank you. I think it was too detailed. I just avoided कितना लंबा ना हो जाए, लेकिन I wanted to touch all these factors because all these are important. Yeah.
Thank you, Dr. Hassan. Actually, you have given a very elaborative description of entire spectrum of coronary artery disease.
Yeah.
I have a small query. In your research project, have you seen any specific difference as far as coronary artery disease risk factor is concerned in Indian youngs as well as in a global perspective?
No, this is we have only seen that is a hyperhomocysteine. I have seen. Okay. I've seen lipoprotein A. In young females, last time about 50 cases, 6 or 7 were having high EPLA. So all these factors have been mentioned. They are in literature. We could find 5 cases of FH. So all these are documented. So these are different sporadic factors, random factors we could identify apart from many cases where we could not identify any factor. And except if there's history of fever or anything, nothing is specific. So we don't know. Because many factors which we know कि हैं, जैसे pollution है, लेकिन हमें पता नहीं उस मरीज में हम कैसे.
You cannot quantify that.
We cannot quantify.
How much it is responsible.
Yeah, this is the challenge. Because PM25 has been highlighted many times. अब आप कहते हैं जाड़ों में डेथ होती है, पर्सन इज गोइंग इन मेट्रो, ट्रैफिक सिग्नल है, PM25 है, स्मॉग है, पॉल्यूशन है, बैड एयर क्वालिटी है, you know all are aware. So you cannot underestimate mental distress and all these other factors also, which may be missing link in many times. Now we require more data. I think we should, because PGI के लोग बैठे हुए हैं, इनसे better community कहाँ मिलेगी? We should be responsible because many times we know that person. अभी हमने कभी suspect नहीं है. So we feel that we feel guilty. हम भी तो नहीं पता लगा, but apparently he was so fit. तो patient कैसे पता लगाएगा? Why he will go?
What was the observation regarding the level of awareness among those patients?
What he will do, वो कहते हैं मैं तो fit हूँ. You will not also say. और वो 22 years की एज में मर जाता है. तो when we should start, when we should suspect. So this becomes a huge problem. आप सबको पता है, there are so many young deaths and they are increasing every day. You read here and there. So this presentation was just to highlight that this topic should be looked as a community, and Starting one project. I will entertain any data from your side to be integrated in this, or we can connect in the better way. You find some interesting cases in a cath lab where you find some factor or some unusual thing. Everything should be incorporated so that we can better study connecting our patient with your patient, and we go back to genetics. Some genetic lab we should integrate. हमें सोचना चाहिए कि मतलब प्रैक्टिकली क्या है फर्स्ट वी शुड बिकॉज कॉस्ट फैक्टर डेफिनेटली कम्स but if it is in project then cost factor can also be taken care of. First we should document what is happening because a lot of answer is hitting in genetics also.
No, any such practical project or registry, we're ready to join. What do you say, Dr. Jain?
Yeah, definitely.
No, registry is fine, so I think it's a way to go forward. And as you rightly said, it's very hard to identify those individuals who will get a coronary event in future, because anyway they are so fit.
Yeah.
People going to gym, suddenly they collapse.
Yeah.
It's almost impossible to find, a flaw in their fitness.
Exactly.
It is very hard.
Very challenging. And you can see whole family is dependent on him, and he's the most healthy person in the family according to everyone. And he dies, and think about family.
And so the only thing which I think you didn't highlight was, what is the role of these protein supplements these guys are taking?
I highlighted protein supplements. It has written that is alanine. Everything is okay.
Yes, sir.
But creatine, they have highlighted creatine if more than 5 grams per day.
Ji.
It is bad, creatine, which is anabolic steroid, and many are taking whole powders without any supervision. And creatine they have shown, and high energy performance, high energy drinks also, they are controversial because they lead to catecholamine surge and high blood sugar, high glycemic index, blood sugar coming down, up and down, and tachycardia. So all these they are unstable things. They can create instability. And creatine they have highlighted, anabolic steroid they lead to inflammatory state and dyslipidemia. Definitely.
Dr. Shastri is here, Dr. Datta.
Yeah.
Comments?
Dr. Professor Hassan, very wonderful talk. You covered very exhaustively.
Thank you.
Couple of things I would mention. Way back in 1998-99, we have collected and analyzed about 1,000 and odd patients with acute MI.
Yeah.
What we found, now I forgot most of it. Unfortunately, it was not accepted for publication anywhere, including Indian Heart Journal.
Yeah.
So that is in 98. And
Yeah.
what we found, people less than 45 years, we didn't have a single patient who was not a smoker or one of the risk factors, smoking, strong family history of premature CAD as you highlighted, or diabetes.
Yeah.
So without any of these three risk factors, at least one of them, there is no patient.
Yeah.
So less than 45 years, very often one of these factors will be there. And it is that way, coronary disease in young is quote unquote preventable because you have the family history of premature coronary disease. And especially in my observation, if mother has premature coronary disease or CAD without other risk factors like diabetes or hypertension, the chance of her male children, having coronary disease, premature coronary disease, very, very high.
Very high.
So as a rule, whenever I see a female patient with premature coronary disease, I strongly advocate that the son should be tested.
Yeah, very good.
And coming to your another risk factor, which you mentioned as homocystinemia, again about 2000 or 2001, I published a paper. We looked at the prevalence of hyperhomocystinemia by different methods. You should read the paper to believe it. And both in case and controls, we found the homocysteine levels to be about 22 milliequivalents, which is equal. There is no difference. But the upper normal in the Western population is 15. So Indians as such have higher homocysteine levels. Now, the one important reason for homocysteine elevation is vitamin B12 deficiency. So nowadays, whenever I see a young patient with coronary disease, MI especially, with lot of thrombus burden, we immediately check vitamin B12 and have an umpteen number of patients. B12 deficiency is there and we correct it. B12 deficiency is a very important risk factor for hyperthrombotic state. Now, the couple of things you didn't mention, of course, about the treatment. But young patients with strong thrombotic burden and a flowing vessel, many times, even in the era without imaging, we used to just wait and see with anticoagulants. Most of them used to avoid a stent. The thrombus burden will decrease over 4 or 5 days of good amount of low molecular heparin, and we should repeat after 5 or 6 days, thrombus burden will come down. And in the era of drug-coated balloons, especially where the topic is coronary disease in young, these patients don't generally have complex lesions. What they have, there is no previous ischemic conditioning. They get a sudden plaque rupture, erosion, and thrombus and MI. So there are no collaterals. They end up having severe LV dysfunction or sudden cardiac death.
Yeah.
So if you have a chance, if the lesion, because the underlying lesion is not very complex, what we do routinely now is if we acute coronary syndrome, young patient, thrombus burden, not much of atherostatic plaque, not complex lesion, we try to do a drug-coated balloon. It may or may not be there in the guidelines, but that is what we prefer to do, because stenting in a young patient, we know every year 2% chance, and he has a long life ahead.
Exactly.
And another important point about prevention, sometime back we collaborated with the WHO, Professor Srinath Reddy. We had a project in the schools. There are half a dozen times probably I went to schools and spoke to the children about all these risk factors, especially trying to, typically adolescents is the age when children get hooked on to smoking and tobacco. So the idea was to prepare them and good healthy lifestyles, games, etc., diet. So there's so much work to do. I think people like you in academic institutions doing a lot of research work, I think you are doing a wonderful job. I think you should continue to do that. Thank you.
Thank you. Thank you, sir.
Just
I
regarding,
think our allotted time is over. What? 1 hour?
Yeah, I
I
don't know whether they say 8 to 9 to 9.
yeah.
No, it is 8 to 10. Yes, the time is unlimited.
Dr. Smith is
Where
there.
do
Oh,
you place,
Dr.
sir?
Hi, Smith, how are you?
My dear
Sir,
Smith.
I am absolutely fine, sir. Where do you place
Okay.
HSCRP? Because CRP is raised with every patient that we get in our chamber.
Yeah.
And where do you place colchicine?
Smith, I was telling, because many times a young person with all the package tests comes with high HSCRP, and he's very worried कि सर इसमें लिख रहा है MI हो जाएगा. But sorry, I cannot tell any drug to counter HSCRP except lifestyle modifications, because colchicine in that I can say reduce weight, control lipid, lifestyle.
Sir, the HSCRP is a non-specific inflammatory marker.
Yeah.
If it is more than 10, you look for systemic causes like infections or inflammatory diseases, arthritis, etc., etc. The HSCRP, what they looked at, the original paper of Paul Ritker and all, within the normal range of 6, less than 6, there is no other cause for inflammatory condition or increased CRP. The people with higher upper quartile, more than 4.5 to 6, they had coronary events. So if somebody comes with HSCRP of 17, 18, I say forget about it, get yourself treated of some any infective inflammatory condition. In the absence of hyperlipidemia, etc., I don't think we have to bother about HSCRP.
Yeah. Same, I was saying same.
So, sir, regarding your...
That is very true, because pollution itself causes higher HSCRP.
Yes.
I tell the patient, even your lice on your head also cause.
Regarding your management of patients who have thrombus, see, the most common presentation is that these young people, they don't have atherosclerotic vessels, but they have thrombus in the vessel. So in last few cases, last few months, what I have been doing is that I don't touch the vessel as such. After doing angio, when I see a lot of thrombus, I give them 1 lakh units of streptokinase in boluses. So up to 5-6 lakh units we give. And the thrombus resolves much faster. And then we manage either on tirofiban or eptifibatide or low molecular weight heparin. And it is so surprising when you check angio after a few weeks, the arteries have all cleared, as Dr. Shastri was telling us. So
we don't require any stent also.
So nothing, not even balloon, nothing. So occasionally in 1 or 2 cases where thrombus was real hard, we just made 1.5 or 2 mm, just to create some way for the thrombolytic to go. And that's what we did. And it just does wonderful well. And OCT images rarely show plaque rupture in these cases. So this is amazing. Just thrombus forming, and most of them are smokers. Most of them are smokers.
I think many
In our study we found,
Yes.
this is way back, I'm telling you about 98,
Okay.
the smokers had better results with thrombolytic therapy than angioplasty.
Oh,
Yeah. So, any other observation, Dr. Anshul? So,
now
I will start this project. I want to go beyond that with the help other risk factors also. Just to, we can't keep discussing these three or any other factors, how to quantify that, your genes level. Let's see how it goes, the project level.
I think
Finances will not be. Yeah.
two things should be projected in the general population.
Yeah.
One is all acute coronary syndrome MI patients less than 45 years aggressively look for those rare risk factors like LPA, homocysteine, etc.
Definitely.
And may not be routinely indicated, but young patients with MI, you should look.
My family history, then
And
definitely.
second thing, the Professor Hassan,
Yeah.
one thing which will decrease the coronary disease incidence and mortality very much is to educate all physicians to prescribe statins to whoever they are treating for diabetes and of course hypertension.
Yeah.
The reason is I'm yet to see a patient, a diabetic patient who has been on statins presenting with acute MI. They may have non-ST elevation MI, acute coronary syndrome, unstable angina, calcified lesions, triple vessel disease, etc. But acute ST elevation MI is very uncommon in patients who have been taking statins. So simply if you can educate our medical fraternity that all people who call themselves physicians, diabetologists, etc., should keep their patients on statins.
You mean to say even if he's freshly diabetic, you start a statin right from first?
Yes, all diabetics should be on statins. Bring them down to LDL cholesterol less than 70. If the LDL cholesterol is still already less than 70, nowadays what I do a coronary calcium score. If it is calcium score is there, then bring it down to less than 55.
Okay, good.
So
The Leno trial has clearly showed.
Statins are directly indicated by all guidelines for diabetic patients who are above 35 years of age.
Absolutely.
I was just going through the study from UK. So they did the CT coronary angiograms for basically for calcium scoring.
Yeah.
Now they found that those few plaques here and there, if this volume was more than 300 millimeter cube, they are the patient they should be on. I mean, it's just a recommendation at the moment because it's not scientifically proven that any patient with a plaque volume of more than 300 millimeter cube on CT angio should be on antiplatelet, I mean aspirin, as well as statin. And as Dr. Shastri said, we should be targeting less than 70 in all of these patients. And if they have high calcium score, less than 55, definitely yes. But this 300 millimeter cube volume, plaque volume, was a news to me because I never read that earlier on.
Yeah.
We should call 1.5 prevention. See, the problem is secondary prevention, all of us give statins and antiplatelets. Primary prevention, the role of antiplatelets is doubtful. Yes. But if you have got a CT coronary angiogram for whatever reason, and our regular coronary angiogram, you find the non-obstructive plaques, 30%, 20% plaques, then I think they should be on aspirin or clopidogrel. Yeah. That is 1.5 prevention.
Definitely. If plaque is there in any artery, then he has to be on it.
Sir, what about diabetic patient, antiplatelet in diabetic patient without CAD?
Without documented CAD, young person, sometimes I may skip, but if they are older or having hypertension, family history, any other risk factor, or even otherwise also bad diabetes, long-standing diabetes requiring multiple drugs, I put them on antiplatelets. Somebody who is just stable on metformin, 500,000 and young patient, probably you can just give statins and wait.
So clopidogrel preferred over aspirin?
Yes, always. But only caveat is check for clopidogrel resistance. Nowadays, I am getting it more and more on my patients. Clopidogrel resistance testing, irrespective of what the literature says. There is a paper in JACC paper, a review article in JACC paper. I think we should read that. The clopidogrel resistance, if you find it, the chance of secondary events is high, whether you put a stent or not. So you should avoid clopidogrel in patients who have got resistance. But any day, clopidogrel is superior, or prasugrel or ticagrelor are superior to aspirin.
Yeah.
I think in diabetic patients, if you are considering putting in on long-term antiplatelet agents without definite evidence of CAD, we should be doing CIMT, carotid intima-medial thickening.
Yeah.
That is
Yes.
one thing. Second thing, ankle brachial index. That is very important. And third thing is, of course, if you have a CT angio or high calcium score, then you might consider. But otherwise, that no.
Agreed. But additionally, suppose somebody is having 10 years diabetes and on insulin, multiple risk factors, also has, they cluster together. Such patient also you can keep. Of course, it's very easy to do ankle brachial index or carotid internal medial thickness. You can yourself can put the probe and you may not measure accurately, but you see some plaque there and there it is.
Yes.
Sir, role of colchicine.
Very doubtful, very bad at the moment.
Yeah.
See, colchicine, if somebody is having recurrent events, you can try, but in those studies, the non-cardiovascular mortality is high. What the presumption is that it will decrease the neutrophil function and probably they succumb to infections. So elderly patients, maybe one event or so you may not give, but some young person for unexplained reason is having multiple events. Probably one can try. I don't know. It is an open thing. There is no guidelines. You may it's your intuition.
Yes.
Dr. Datta? So I think that was Smith.
Yes, sir. We can, if there are no more questions, sir, we can.
Yeah. So, sir, it was wonderful to hear to this illustrative talk.
But if I'm ready with the project, I will interact you again in the next meeting, and I will like cooperation input from all of you all,
Sure,
because
sir.
it will help in better understanding. Yeah.
Thank you, sir. Thank you so much, sir.
Thank you very much, Professor Hassan and everybody. Thank you.
Thank you, sir.
Thank
Thank
you.
you so much.
Thank
Good
you.
night.
Bye. Good night.
Thank you. Good night, Smith.
Good night.
Good night.
Gudiya. Gudiya. Hey, Gudiya. Zara. मेरी बब्बू ये लीव करो